Good morning. It's great to see such a wonderful crowd here today. So many people. I'd just like to say a few words before we start. About this conference, I think the most important thing about this conference is it's a conference of hope. Because of the dialogue and the relationship building that will come out of this conference. We are forging a relationship at CNETS Canada with the US and Europe and beyond, and we're going to keep building on this for the betterment of our community. Networks of expertise, they need to work to take the patient beyond the confines of a totally prescriptive approach to care to becoming partners in care, physicians and patients becoming partners in care. This conference is beginning to address the idea as well of a patient-physician collaboration designed to advance genuine advocacy as we move forward in our relationship with government and cancer agencies. Let me see. I am touched by the openness of the physicians yesterday and the day before who expressed differences of opinion, who were relaxed enough and open enough or compelled to express differences of opinion in front of the patient community. And this gives us hope, gives me hope for openness in regard to the idea of second opinions. We can, because we see here at the conference physicians differing on how they would approach an issue. That means that we can feel free to understand that and understand that we need second opinions, maybe often, not just occasionally. Patients need to be part of the patient-physician collaboration more and more, as we've come to understand more than ever that there are many ways to take action on our own behalf. And patients need to become extremely educated because of the need to understand the different approaches to diagnosis and treatment available today. Understanding can lead to a longer and more productive life. And I think I have one more comment. Yes. I would like to introduce Dr. Sandy McEwen, who is going to lead the first session on consensus statements.
So, Maureen, thank you very much. And again, my congratulations. I have never seen a group of people who have sat through lectures more assiduously and intently. I'm in awe of your patience, so congratulations. So this morning's session is looking at guidelines from 4 different groups. There are broad similarities in the guidelines. There are some differences. And at the end of the session, when we have our round table, I'd like to encourage you to say what you need out of the guidelines. I think it's important that we have the scientific and medical rigor within the guidelines to ensure that we are offering you the best path forward. But at the end of the day, they need to reflect also your needs. So I hope that as we approach that discussion, we will do it in that sense. So I'm very pleased to start with the Canadian guidelines, and Dr. Ralph Wong from Winnipeg is going to present an overview of the Canadian guidelines. None of these talks are very long, but each of them have attempted to identify issues which we think are critical as we move forward. So, Ralph, thank you so much.
Thanks, Sandy. So it's my pleasure to present the Canadian guidelines, which were originally published in 2006, and then in 2008 they were updated, but due to a number of unforeseen factors, they're just about to be published in Current Oncology in the June edition. So this is the first presentation of these guidelines. And I start the talk with this picture that I took. I dragged my poor wife on our honeymoon to Africa and began our married life together, slogging up a mountain, hypoxic and sleeping in separate beds. Usually that doesn't happen for a while. So anyways, this is a picture taken from our Jeep in the Serengeti. And I thought it was very appropriate to start the talk with this picture of zebras. So the consensus recommendations are generally for the well-differentiated GEP tumors, and it's a revised statement, and Walter Kosha, who unfortunately is not here today, is the primary author, and it represents, the authors are a group of medical oncologists as well as surgical oncologists. Yes, there's Peter Matrakis is not on that, and he should be. Anyways, that's my mistake. So these are a revised statement of the Canadian National Expert Group, which, like I said, is about to be published. So just before we talk, there are categories of consensus. There's guidelines on writing guidelines, believe it or not. And guidelines, as pointed out by Dr. Kosha, are just basically, there's a problem, there can be a problem because they can turn out to be like the Ten Commandments written in stone. But they are simply guidelines, they're simply advice on how to treat these patients. And there are categories of consensus, and ideally you want to get a category 1, which is a well-randomized clinical trial which clearly sets out one question and answers it. So, for example, the PROMID trial would be of that category. But because of the relatively rarity of this disease, all of the guideline recommendations on the Canadian side are category 2A, based on lower level of evidence, including clinical experience, and it's a uniform consensus. So we have one category 1 and majority of category 2A, but that is the best available evidence. So I won't go through the introduction. We're talking about well-differentiated neuroendocrine tumors, are relatively rare. The reason we started these in 2006 was because there was no defined approach throughout the country, and we felt it was time to get a defined approach. And these are updating the 2006 guidelines. So, as well aware, the incidence is increasing, whether that's real or just picking up better diagnosis is not known. The pathology classification there's a number of them proposed, and the group actually felt that the WHO classification was the best. There are concerns about the ENETS TNM system as well as the AGCC 2009 staging systems that was expressed in the guidelines. So our pathology, our first set of guidelines was that the use of the 2007 WHO classification is recommended in order to ensure consistency. However, known or possible features of prognostic significance should be routinely reported, and that'll be on the next slide. And the proposed staging may be used with the caveat that this system still requires prospective validation. And it is recommended, because of the rarity of this disease, that the review of the pathological specimens should be done at high-volume centers to maximize consistency of reporting and ensuring proper management. And so the following elements we had recommended to include, specifically we wanted to include this so that we can ensure that Ki-67 is reported in the pathology report, although at least in Winnipeg, I'm consistently sending back my pathology reports because of missing data, particularly the Ki-67. Dividing the nets into two types, the functioning nets, which typically are the carcinoid syndrome, which everyone is aware about, and the non-functioning nets. And the biochemical markers, which were recommended, were the 5-HIAA and the chromogranin A. And there are issues currently in Canada about the availability of chromogranin A. Some centers do this, some don't. Some fund it, some don't. We in Winnipeg, in Manitoba, don't do this test, but we send it to the Mayo Clinic, and they do it for us. Now, is it cheaper for us to send it to somewhere in the States or somewhere in Canada is not known. So there is actually a group of within the guidelines group who are actually trying to sort out where to get uniform chromogranin A for patients throughout the country, and it's all over the place depending on which province you're in. So our recommendations are that they should be measured at time of diagnosis for all patients. In asymptomatic patients who have undergone complete resection and show no signs of disease, the chromogranulation should be evaluated as part of the annual surveillance. And in patients with active and functioning disease, the 5-HIAA and chromogranulation should be used to monitor treatment, follow up and changes in symptomatology, and evaluate for tumor growth. It is important to note, however, that people can have highly elevated 5-HIAA, and I have a patient whose HIAA is 300. She's asymptomatic, and she refuses to go on somatostatin because she does not want the injections. So you can have people with extremely high HIAs that are asymptomatic, and you can have people with normal, under 35 HIAs that are classic symptoms of carcinoid syndrome. The diagnostic imaging are conventional imaging versus other imaging, and our recommendations with the baseline screening should be a triphasic CT of the liver, indium-111 scintigraphy, and or MIBG scintigraphy, depending of whether the patient is octreotide positive. A PET scan currently has limited role. Winnipeg does have access to a PET scanner, and we do not use it except in the poorly differentiated tumors. We don't have access to the newer forms of PET that are available in Europe. Imaging modalities for postoperative evaluation include the usual and should include the most sensitive imaging modality determined at diagnosis. But they should be individualized depending on the patient. For surgical management, early intervention may maximize the chance of successful surgery. Consider prophylactic cholecystectomy for those undergoing surgery, especially for those that are considering being put on an SSA. We need a good communication between the surgery and anesthesia team, and octreotide must be administered during the time of surgery to avoid a carcinoid crisis. Definitive resection of the primary tumor should be always performed, regardless of whether they have metastatic disease or not. It's been a fight and a battle in Winnipeg to persuade my surgeons to go after a small bowel primary with presence of metastatic disease. Patients with functioning tumors, short-acting SSA should be given, and with localized and regional resectable metastatic disease, curative disease should be considered if technically and clinically feasible. And this was actually the most controversial part of our guidelines. But it was felt that if you could resect everything, even though the chances would be that the tumor was going to come back, you would set the clock back. So cytoreductive surgery should be continued. They should be, however, all surgical approaches do not fit everybody, so they should be individualized. And we strongly recommended that they should be only undertaken by surgeons and centers who have expertise and experience with these tumors. And that unresectable liver disease may be considered for TACE, that's the transarterial chemoembolization, or radioembolization, depending on what's available at your center. The medical management, we felt that certainly the SSA, the analogs, octreotide, it was indicated for the functioning nets. There was a talk yesterday on lanreotide, and it is available in Canada, but it's not approved for neuroendocrine tumors. In Canada, the drug is approved for acromegaly. So whether or not you'll be able to have that drug because it's easier to give than octreotide would be dependent on your individual province and funding. 5-HIA is a predictor of cardiac complications, and this was a recommendation that all patients with elevated 5-HIAA, even if they are not symptomatic, should be considered for therapy. For the non-functioning tumors, the role was under debate until the PROMID trial, which we've discussed previously, showed that there was tumor stabilization and increase in progression-free survival with 30 milligrams of octreotide LAR versus placebo. And so this is our level 1 recommendation, that sufficient evidence now exists to recommend this use of this drug in newly diagnosed treatment-naive patients, whether they're functioning or not. And by extension, we also recommend, even though it's not covered in the clinical trial, that foregut and hindgut tumors also be considered for this treatment as well. Other treatment options include interferon. It still has its use. Cytotoxic treatment for patients with high Ki-67s. And we specifically did not recommend one cytotoxic treatment or another because there's a number of them out there. And consider the use of new agents such as imatinib and the mTOR inhibitors. We know that the RADIANT-3 trial is going to hopefully be reported at ESMO in Milan in October. And the new SSAS, which were discussed yesterday. And other agents as required depending on the symptomatology. So our medical recommendations were fairly clear that the somatostatin analogs, the SSAs, are the primary treatment for patients with symptomatic secretory tumors. It's also recommended for patients with asymptomatic progressive disease based on the PROMID trial. SSAs should also be used to prevent or treat carcinoid crisis. Interferon alpha, alone or in combination, may be used. And cytotoxic may be a first-line treatment for patients with a high proliferation rate based on the Ki-67. We also put in some guidelines for monitoring and follow-up, and there's no level 1 evidence about what's appropriate. Unlike, for example, the ASCO guidelines for colon cancer, which are based on randomized trials, this was felt to be a reasonable approach to standardize the care and follow-up of patients. And we divided them up into different types, different situations. So the first one was the low-risk group of a small primary, low Ki-67. Then the second was a high-risk group, and defined by a large primary, a nodal involvement, or a high Ki-67. Then there was metastatic disease or post-debulking, post-resection, where all the macroscopic disease was removed. So we're assuming that there's microscopic disease present. And then metastatic disease or post-debulking where there's macroscopic residual disease present. So the guidelines were divided up into different clinical scenarios, and we felt this was a lot of discussion about what would be appropriate, especially using chromogranin A, where there's difficulties obtaining this, and the 5-HIA, which all of you know is a hassle to collect for the 24-hour urine. The patients should be stratified accordingly and followed accordingly more frequently in the first year after diagnosis to determine what the, quote, tempo, so how aggressive is disease and then at regular intervals, and that people with elevated 5-HIA should be routinely evaluated for carcinoid heart disease. And then our final part of our guidelines was on carcinoid heart disease. This has generated a lot of discussion when we were trying to write the guidelines. As we found out yesterday, the incidence of this condition seems to be dropping. So patients with carcinoid syndrome should have a baseline echocardiogram, and all patients, in fact, should have an annual echocardiogram. We felt that an annual one was reasonable, given the difficulty in accessing echocardiograms in the different centers. And a referral should be to the appropriate people if cardiac abnormalities are diagnosed. Early intervention with octreotide should be considered for patients with persistently elevated 5-HIA. Because long-term low-level exposure to serotonin may cause cardiac complications, reduction of the urine excretion is an appropriate goal, even normalization if possible. So in summary, there's a high index of suspicion can facilitate early diagnosis and early referrals. We felt strongly that optimal therapy should be done by a multidisciplinary team in specialized centers, that SSA therapy is the primary treatment for the choice of functioning tumors, and that octreotide LAR is also recommended for patients with non-functioning tumors. And that was just a recent picture that I took. As people recognize, that's Ayers Rock, Uluru, in Australia, just to prove that medical oncologists have a life outside of their jobs. And that's sunset. And it was actually this to be in the wettest summer in Australia in 150 years. And that's all green. It doesn't project very well, but there's actually, the whole desert is green, which is extremely unusual. Thank you very much.